Thank you all. Good morning, everyone. Thank you for this honor to allow me to present this morning at Grand Rounds. So I have a case presentation that I'd love to share with you all. So here we have a 62-year-old female. She presented with right lower extremity pain for 10 days. It was mild, generalized, and non-radiating. She also stated that she was having some swelling that she was noticing at her ankle on the right side, but otherwise her review of systems was completely negative. So no chest pain, shortness of breath, or palpitations, no syncopal episodes, hemoptysis, paresthesias, erythema, no skin changes whatsoever. She also had no cancer history, no COVID history, and no recent travel. Upon further questioning, we find out that 14 days ago, she had underwent a right GSV radiofrequency ablation at a clinic outside of CVR, vein clinic that was not CVR's. And 10 days ago, she informed them of her new onset right lower extremity pain and swelling. So she asked them to perform an ultrasound on her. They informed her that she had a small blood clot in her right thigh, and they prescribed her Eliquis 5 milligrams BID for 7 days. She felt a little anxious about the situation, about, just about everything that was going on. So she decided to come to CVR for a second opinion. She had not missed any doses of her anticoagulation, and she had been compliant with her thigh-high compression stockings. When we asked her about her past medical history, she said that she had anxiety, hyperlipidemia, and 20 years ago, she had a provoked blood clot. It was in her calf vein, she said, and it was after a long plane ride. She had completed a 3-month course of a blood thinner at that time. Otherwise, she's on Xanax, PRN, atorvastatin, and vitamin D. She had no surgical history. She was a never smoker, no drug or alcohol use. Her father did have history of DVTs, and she had no known drug allergies. She was up to date on her age-appropriate cancer screening. Upon physical exam, she was non-hypoxic, normotensive, and her heart and respiratory rate were within normal limits. Her exam was completely unremarkable other than having the right lower extremity ankle edema. So now we've come to a point in our case where we need to make a decision of what to do next. So as far as our medical decision-making pathway is concerned, I had a couple of choices in my mind. Either we could do no action. She's on anticoagulation. She tells me she has a blood clot, and that's it. I just keep her on it and I let her go. Or I increase her compression stockings, or I repeat her ultrasound to determine the exact location and extent of this clot that she was told she has, or I switch her to aspirin. So of course, to be the most thorough and to treat her appropriately. I'm sorry, Dr. Pappas?
Procedure that you had done. Are you sure it was a radio frequency or a laser?
No, it was a radio frequency ablation.
And you're sure it was 2 weeks ago?
Yeah, she told us 14 days ago.
And her only presenting complaint when she came to see was some mild ankle swelling?
Yes, and then she said that she had developed pain 4 days after the procedure. And not in the location of her incision, it was by the groin.
But she's been anticoagulated now allegedly for 10 days.
She said that she had been on she had been on the Eliquis since they prescribed it to her. Yep.
Yeah, but they never gave her a loading dose, correct? They just gave her the 5
milligrams. They did not, correct. They did not load her. They only gave her 5 milligrams.
Okay. Well, 5 milligrams once a day or twice a day?
Twice a day.
Okay. All right. Thank you.
Yeah. So at this point, of course, we would want to repeat her ultrasound and determine the location and extent of her clot. She has a history of DVTs. She's now presenting with a symptomatic blood clot. An EHIT is suspected, but she is symptomatic, and the timing also, as Dr. Pappas was mentioning, is important. So we did go ahead and performed a lower extremity venous ultrasound. And as you can see in the right common femoral vein, if you take a look, there was an acute EHIT 3. A better view would be here with the color. As you can see this clot right here. And in these still images, to be quite honest, these still images do not capture in real life the extent of the clot, but it was greater than 50% of the lumen. And as I go on with the slides, you'll see some other components of this clot that we had been noticing. It was 3.3 centimeters in length, at least, if not a little bit longer. And I'll get into that later in this presentation. Otherwise, if you continue down to the femoral vein throughout the thigh, that was negative for blood clot. Her popliteal was open as well. When you got to her gastrix, she did have a chronic thrombosis of the gastrocnemius vein, and her PTVs and PVs were fully compressible. So I'd like to take a moment to pause in this case to go over EHITs and risk factors, prevention, and how to clinically classify them as well as manage them. Here we have Dr. Sufyan's paper of incidence, progression, and risk factors for endovenous heat-induced thrombosis after radiofrequency ablation. This was a wonderful paper that had, described a lot of the very important things that a practitioner should know when it comes to EHITs. As far as the risk factors for development of EHIT, this paper had presented that large vein diameter, male sex, and multiple phlebectomies were risk factors for development of EHIT. Interestingly, they had recommended that EHIT class 1 and 2 be managed with observation or antiplatelets or both, and then class 3 or 4 should be anticoagulated. So next I went through to the AVF consensus and guidelines, and I have pulled some information from that document as well. So here we have EHITs. They are superficial thrombus in a treated vein segment is completely normal. However, when it propagates into a deep vein, that's when it may pose a risk for the development of a PE. Most of the time, EHITs are asymptomatic. They behave like stable thrombus. They often regress spontaneously within just a few weeks, either with observation or anticoagulation. EHITs rates at the time of publication, which was 2021 of this consensus statement, was 0 to 3%. Most are asymptomatic. However, it has been associated with rare cases of PE. An EHIT is considered anatomically a form of DVT, but its clinical course is often much more benign than an unprovoked DVT. When they looked at animal studies and they looked at histological specimens of a classic DVT versus EHIT histology, it was seen that the EHIT histology specimens had significantly higher hypercellular response, fibroblastic reaction, and edema, as well as more echogenicity. So there is a difference between the classic DVT histology and the EHIT histology. Preliminary human studies were also confirming of this, and most EHITs will develop within 72 hours, but they can occur up to 4 weeks post-procedure. The consensus statement did note that there's a controversial point of whether an EHIT occurring more than 1 week can be regarded as an EHIT or a classic DVT, but it was classified from 72 hours to up to 4 weeks post-procedure. Here we have a breakdown of how we would approach EHITs. So you have your class 1A here, and as you can see where that occlusion is ending, and class 1B where the occlusion is ending here. Once you've entered class 2, it's getting into that deep vein and there's less than 50% of the lumen involved, whereas class 3, you've got greater than 50% of that lumen involved, and then class 4 is completely occlusive. So in our situation, we had a class 3, which was the thrombus propagation was greater than 50% of that deep vein. When the consensus statement was put out, they had recommended with a 2C recommendation that the risk factors were large GSV diameters, previous venous thromboembolic disease, and male gender. But as you know, I had mentioned from Dr. Sufyan's paper what risk factors they had mentioned from there. And then for prevention, it was also a 2C recommendation, and it was mentioning increasing that ablation, making sure that distance is far enough from the deep SFJ. As you can see here, when they reviewed all of the papers, and Dr. Sufyan's paper is in here, the EHIT risk factors were all over the board. Every study had different EHIT risk factors that were seen to be significant, and there was a lot of differences between studies on what risk factors they found to be appropriate. So now that I have determined that my patient has an EHIT 3, it is time for me to decide what to do to this patient. Should I be continuing my Eliquis at 5 milligrams BID and repeating the ultrasound in 1 week? Should I be evaluating for a potential IVC filter placement at this point, or should I be switching this patient to aspirin? So as Dr. Pappas had mentioned, ideally this patient should have been loaded with the 10 milligrams BID in the first place, but definitely this patient requires full anticoagulation and a repeat ultrasound in 1 week had this been an EHIT 3 with no other abnormalities seen on ultrasound. And as you can see here with EHIT 1, like Dr. Sufyan's paper had mentioned with 2C recommendation, you do surveillance or antiplatelets here in classification number 2, you do this weekly surveillance, and then they mention antiplatelet versus anticoagulation in high-risk patients. And in EHIT 3, you're going to be treating with therapeutic anticoagulation and weekly surveillance. You would discontinue this treatment once the thrombus has retracted or resolved. And with EHIT 4, you're treating it as if it's a full DVT, and you're taking into account risks and benefits, and you're individualizing this treatment for the patient based on CHEST guidelines. Now, here at CVR, we don't just report EHIT 3 and call it a day. We want to make sure that we do a very thorough inspection of exactly what we're looking at. Anybody can check a mark, okay, it's EHIT 3 and be done, but we go above and beyond with our ultrasounds, and our vascular techs are absolutely amazing in catching the nuances when it comes to these sort of thromboses. So here I'd like to play a video of what our EHIT was truly looking like. This is a representative video of what was happening, but as you can see here, we have a mobile clot. So with every breath that our patient was taking, that thrombosis was just flapping in the wind, and you can see a significant volume of the EHIT was completely detached from the sides of the veins, and was within the lumen, and it was moving up and down with every breath that she was taking. So we determined that this EHIT 3 was a mobile EHIT 3, and that was very important to us, given, this patient has had history of DVTs in the past. You need to make sure you take into account their cardiopulmonary reserve, whether they've had PEs in the past, to really get that detailed history to figure out exactly how you're going to risk stratify this patient and determine next steps. So now we've come to another, point in our medical decision-making pathway. And this first point as well, do you want to continue the 5 milligrams BID and follow up in 3 months? But she never got that loading dose, so that's a little concerning. And also, do you really want to wait 3 months to follow up a patient like this when she has a mobile clot that you can see moving with every breath? Do you want to load her with Eliquis 10 milligrams BID, closer monitoring and evaluating her for potential IVC filter placement or even clot retrieval at this point? Or do you want to just switch her to aspirin and call it a day? So of course, we are now more concerned for this patient, given that this was a mobile EHIT 3. She never got the appropriate loading dose. And so we had chosen to load her with the 10 milligrams BID. And after discussion with Dr. Varma and also involving the primary care physician, it was determined that we would send this patient for closer monitoring in the hospital and evaluate her for potential IVC filter placement or clot retrieval. And, the length, the mobility of the EHIT, all of these things, the fact that she was on 5 milligrams, never got the full dose, all of these things had made us want to monitor her more closely and get her evaluated for further intervention other than just keeping her on anticoagulation. So when I went to the literature to try to understand this case better and to try to understand the clinical medical decision making, I went all the way back to 1990, which is one of the first papers that I found where they were trying to determine the clinical significance of free-floating venous thrombi. And as I continued to read the literature throughout the years, I'm reading all of these papers that are coming out, and I'm reading the consensus statements, and now I'm reading guidelines of all different kinds. I'm looking at SIR, I'm looking at ACR, I'm looking at ACC, AHA. And I came to a few conclusions after reading all of these. The first conclusion was the fact that there were not many randomized controlled trials discussing specifically mobile venous thrombi. One, so that was very important for me to note on my literature search. Two, after going through every single guideline and going through the different versions of the guidelines, free-floating or mobile venous thrombi were not addressed in all of the guidelines from these big, like ACR and ACC, AHA. If it was mentioned at all, it was not a clear cut, this is what you should do. No algorithms were provided. It was more so about a case-by-case basis, consider it, may not be appropriate, not recommended. And there was a lot of change. There was more appropriate use many years ago. And now when it comes to using, for example, IVC filters for the treatment of free-floating venous thrombi, along with anticoagulation, there was a lot more hesitation. There was only, maybe appropriate or not supported or not recommended. So what I've gathered after doing this, an extensive literature search on what next steps would be appropriate as far as putting an IVC filter or doing an intervention on top of a blood thinner for this kind of free-floating or mobile iliofemoral IVC kind of thrombus, to put it in that category, you could see that there was not a lot of high quality evidence to back up one way or the other. There was a lot of experience involved, a lot of changes throughout the time in regards to these guidelines. Really quickly, one word about filters. You have your permanent filters and then you have your retrievable filters. And the filter would be placed in here, as you can see, it's being placed from up top, but you could also go in from the groin, and it would be placed here in the IVC to catch any of those extra thrombi. At the moment, guidelines recommend it for contraindication to anticoagulation. However, as I had mentioned before, whether or not you would consider it in a case like this seemed very provider dependent. It was left to the provider to do it on a case-by-case basis. So this is why I'd love to open the floor to our experienced members of the audience, and I'd love to hear your words of wisdom in regards to how you would have approached the case and how you would have approached adding interventions other than full dose anticoagulation to this patient.
Okay, so let's open it up to the floor. I have a few thoughts, but I'd like to hear what everybody else has to say. Dr. Sufyan, what do you think? You're our resident EHIT expert.
Yeah, I will put my neck out, and I said I would probably in this patient go on full anticoagulation and follow her carefully, and I would not go for filter immediately. Having said that, I want to warn everybody that when you follow up, you have to be very careful with the ultrasound. When you do the ultrasound, the compression part it can be dangerous. Yeah. We have, if you guys remember, we reported a case before even our original paper on a patient who came with EHIT 2 for a follow-up, and the technician nicely identified it and finished her study, and then she went back to take a picture, and she couldn't see it. She called me, and funny enough, I was in a meeting in New York, and I immediately called and I said, I know where it is in the lung. So sure enough, this was a PE that we reported, and we called it at the time the disappearing EHIT. And so when you tell your technicians, please be careful and use Valsalva and so on, but don't compress too much. So I would be careful not to cause the dislodgement by myself, but I will be I would like to hear others. I would hesitate to put a filter, Peter.
Yeah, Dr. Sufyan, when I had read through the literature, there were many case reports of that exactly, where the ultrasound tech was looking at the groin and, documenting this, and then actually right after compression, it was seen that it turned into a PE. So that was seen in other studies as well.
Oh, I'm glad to hear that, because I didn't know that. Ours was the first. And interestingly, it was before Journal of Vascular Surgery, Venous and Lymphatic was even started, and it was reported in the original Journal of Vascular Surgery.
So one of the things that struck me about your presentation was that 1990 paper.
Mhm.
So in 1993, I'm starting my fellowship, and we have a patient that has a free floating thrombus in the common iliac vein. So I remember when I did my first literature search when I was a fellow, I found an article from the Archives of Internal Medicine that had 83 free floating thrombi. All of them were anticoagulated, and only one of them eventually ever embolized. So I remember there's always a lot of hype and concern that these things are free floating and, oh my God, they're going to break loose. But the reality is, if you anticoagulate them, most of them actually just kind of adhere to the wall and then eventually just get dissolve or go away like most clots do. Now that's a DVT. I don't know if a EHIT will behave the same way. So my personal bias is to do what Dr. Sufyan said. I just anticoagulate these patients. I don't necessarily send them for a filter. Now, that's also changed because, again, in the 90s, we used to put filters in everybody like it was candy. We always say, oh, there's no long-term consequences for it. And now we know that depending upon what kind of filter you put in, there could be potentially large long-term consequences. Because, we all got spoiled by the Greenfield filter as to how safe it was. And then all these other filter designs came out, and then you had problems with them. And we also know that if you put a retrievable filter in, the retrieval rate is really low. On average, or somewhere in the low 20s, even if you put a temporary filter and you tell these people to come back. So, I'm not a big fan of putting filters in anymore, these people, especially if proper anticoagulation is done. I think the other thing in the decision-making tree that you didn't mention in your presentation was the fact that now this is her second clot and she has a family history of clotting, and no one's mentioned doing a hypercoagulable workup in this patient, because that's going to change your decision-making tree. Because if she comes back positive, now we're discussing whether or not she should stay on it for life and whether or not her family members should also be checked for this as well. So, but the real question is, how often do you see these EHIT-3s? Because if you talk to enough people around the world, in the Netherlands, they don't do a 3-day or a 7-day scan. They do a 6-week scan. But I always say to my friends in the Netherlands, but you have a socialized healthcare system. If you have an embolus, you're not going to get sued, because the government is basically the insurance company, and they're not going to pay for these things. So we live in a completely different medical legal environment here in the States.
Right.
So, I think the other thing that struck me is, ever since I joined CVR and I watched the QA process here, these EHIT-3s and 4s actually occur a lot more than you would think. Because once you start looking for them, you realize it's more common. Even myself, I'll speak for myself, I get 4 to 6 a year. And I think I'm pretty careful, but you just never know. They happen sometimes. So I would anticoagulate this patient like you did. I wouldn't send them for a filter. The other option is, depending upon how concerned you are, is we had a similar situation in, I believe it was in the Connecticut area. I think it was one of Dr. Edelman's patients who had a free-floating EGIT, and it was on a very, very thin stalk. If there was going to be one that was going to embolize, it was this one. And they sent them to interventional radiology, and they put a clot retriever in there and basically just sucked it out. And they confirmed that they got it because they looked at the catheter and what came out of it, and it was the thrombus. So, depending upon your level of concern, if you really think that it's highly, mobile with a very thin stalk, that to me is another option, which avoids putting the filter in as well.
Peter, if I may reiterate, just like your experience in your training with filters, even before that, I remember when I was my chief residency, among the earliest filters put, it was Mubin Uden. You guys may not know moving urine places hard, but it was the first one, and I was allowed to put it. And interestingly, the second day, the patient was coded, and we found the filter not on in the cava, but in the iliac. And from then on, I became very scared of all filters. And so there are, you kind of become very cautious. And now we know we have safe, but they are not that safe. The other point you made about doing ultrasound on the third floor, this is really, it's because finance, it is all has to do with how much money you pay and so on. And socialized medicine is different. Here, the debate is turning towards not doing. We have a paper for next month in Journal Club to discuss this case, this issue. And interestingly, I found this week the entire online communications among members of the American Venous Forum is on the topic of to do or not to do on the first week. And I thought everybody will be not doing, but the consensus seems to be most people are still afraid and are doing for good reason. It is surprising to me. It's surprising to me.
Yeah, I mean, look, I think if we're all honest, we realize that most of these e-hits are innocuous. You know, I think somebody did an analysis once that you have to do like 10,000 scans in order to prevent one pulmonary embolus. But the problem is our legal system hasn't caught up with our literature. You're going to find some, well, let me be nice, some doctor who's going to say that you should have scanned them. You know, so I'm sorry, you know, until the legal system changes, I think we're still obligated to check. And let's be honest, again, I think the EHIT 3s and 4s occur a little bit more often than we were led to believe if you just read the literature. Since we're a large volume institution, you know, and Teresa reports these, we see how often it occurs. And quite frankly, if you catch a 3 or a 4 and you put them on an anticoagulant, you probably, you know, you don't know how many of those patients you save from having a PE. And the difference is now, when Dr. Sufin and I trained, we didn't, all we had was Coumadin. So all of these patients would have had to have been admitted to the hospital, placed on IV heparin, then switched over to Coumadin. That was like a week-long process. Now you just start them on a DOAC and it's not a big deal. You know, the other thing that I wanted to say from your presentation, I'm still not quite sure how symptomatic this patient was. You know, every patient after you do an RF ablation has thigh pain or groin pain. Mm-hmm. And, you know, and I wouldn't, with a little bit of ankle swelling, I would have said, don't worry about it. That's normal. Mm-hmm. Don't worry about it. So if we had done the 3-day scan on this patient and it was negative and the patient came with a little thigh pain, I don't know if I would have scanned this patient, to be perfectly honest with you. So anybody else have any questions or comments on this?
Yeah, Peter, I'd like to make a comment. You know, you see these EHIT 3s and 4s, and then if you treat them and maybe they're gone in a week or 2 or 3, I've often wondered how many of them turned into subclinical PEs that, you know, the patient didn't even notice. And we just assume they dissolved or retracted.
That's a very good question. We really do not know.
No, but the
I
point
think it happens more than we realize.
If that happens, how long do you treat them for? If you treated them for a week and it's not there, do you stop? Me personally, I agree with you, Phil. If they were subclinical PEs, I don't stop the treatment at 1 week. I mean, I give them a minimum of a month at that point, just you know, to say that I gave them long-term treatment, you know, in case some other.
Yeah, I do too, but I've always just wondered how many of these, I mean, we see people all the time who have little subclinical findings and, you know, subsegmental lobar clot probably, and they're completely asymptomatic.
Yep. No, I agree.
Good morning, all. It's Les Cunningham. I wanted to follow up with what Dr. Chapis had to say. You know, over the course of doing vascular surgery for a long time, we've obviously seen a lot of DVT consults. And the thing that's always struck me is we spend a lot of time worrying about the diagnosis of PE, but rarely can sort of tie the DVT to the PE, except in those patients that are severely symptomatic. It strikes me that we're spending a lot of time talking about trying to prevent a PE. Question would be how many of the people that we think have had PEs were actually symptomatic. And I don't know about you, but I've never really seen that reported in the literature that Aditi was referring to, because they don't really talk too much about that. So if you look at the E-hits, you look at resolution, you look at a lot of things, and even if they make a diagnosis of PE, it's usually in symptomatic patients, and it's the symptoms that drove them to the diagnosis of the PE, not any of the things that we're looking at with ultrasound. Does that change the way you think about it? I guess traditionally for me, it has. I hear what you're saying. If I'm worried enough to start somebody on anticoagulation because of the thoughts you had, Peter, if the clot's resolving and they're going to have a PE, it's nice to know that the anticoagulation is there for a little bit longer. I guess I'm asking, should I be more worried about the PEs? Traditionally, I have not been. I don't think of a filter as a form of treatment. It's just another preventative measure. And is my risk from the preventative measure worth an asymptomatic PE in a patient that's anticoagulated? Difficult question for me. I've traditionally been biased to not place filters in those patients if they can be anticoagulated. Your thoughts?
Yeah, no, I'm on the same page as you. I'm not a big fan of filters anymore. I try to avoid them like the plague, especially after the FDA came out with that comment that if you place it, you're obligated to follow them and you're responsible for any complications that ensue afterwards. So that's a heavy lift. So I agree with you. And the other part is, I think the point that you made that's key, the vast majority of these patients are asymptomatic. It's very, very rare that you'll see, like occasionally when I was still doing inpatient medicine, like you said, you get these consults for a DVT, you do a scan, you'd see it in the groin, and then you repeat the scan 3 or 4 days later, it's gone, and then you do a CT scan in their chest, and you wouldn't have known hadn't you looked for it. So I think if we're all being honest, are we treating the patient or are we treating the chart for the lawyers? I think more often we're probably treating the chart. But there is some data, if you talk to the pulmonologist, though, about DVTs that ended up becoming PEs, they're very adamant that those patients should be treated for 3 to 6 months. And when I asked some of the leading pulmonologists why they feel this way, they said that if the pulmonary embolus was a result of, say, like a femoral vein clot, that if you don't fully anticoagulate them for at least 3 to 6 months, their recurrence rates are almost 3 times higher than if you did anticoagulate them, the recurrent PE rate. So that's the reason they give to treat them, is because they feel that it decreases their recurrence rates.
I'm assuming that that's for de novo DVTs as opposed to the E-hits.
Correct.
Yeah,
that's correct.
And one of the things that's really struck me as well, I had the misfortune of starting, to use these catheter heat-based things a while ago, and had a lot of experience with E-hit early in my life. And it just, even before the data came out, it always struck me how benign the course of that was. And obviously we were much more aggressive early on with the anticoagulation. But after a while, because of the difficulties in getting people anticoagulated, we just learned about the benign nature of it. And I don't want to be glib, but that really is now supported by the data as opposed to just my personal experience.
Yeah, in the late 90s, when we first started doing these and we didn't know how they behaved, I used to put people on Lovenox, and now it seems like overkill, especially for the E-hit 1s and 2s. Most of them resolve within a week and they're retracted. Mm-hmm. And it brings up the issue about whether or not we should even be documenting E-hit 1s and 2s now. As I think it's pretty clear that 1s and 2s are completely benign, so we probably should just be focusing on 3s and 4s. But again, it's a good QA process. I think it's good to kind of know. Especially if you get 3 or 4 E-hit 1s or 2s in a row, then maybe you should be looking at what you're doing, because that's unusual. But other than that, I'm not quite sure why, or the value of recording 1s and 2s anymore. But I think, again, CVR is a target. We're the largest, vein provider in the country, and I would rather have more data to support what we're doing than less. So.
Peter, it is the historical nature of the fact that we as vascular surgeons were scared with D-hit because of the first paper by Hingorani that was presented, and it was reporting, if I'm correct, about 17%
Yeah.
And that really never left until a lot of data, including ours, both for RF and radio frequency and laser came out. So that kept in our mind that it is a very high thing. And it is a historically kind of, we were intimidated to begin with. And then
I always thought,
really,
Dr. Sufi, that paper was an anomaly because no other group ever presented that kind of e-hit rate. Everybody was like less than 1%. They're the only one that had a 16, 17% e-hit 1 rate. So, but you're right. It did scare the crap out of people at the time and made people rethink what they were doing a little bit. And quite honestly, remember when we first started doing this, we were only 2.5 centimeters away from the junction. I think that paper prompted people to pull the catheter back a little bit further. So who knows?
I think we also live in this era where you get any hit 1 or 2 and you disclose it to the patient. And there's a number of patients that provokes incredible amount of anxiety and distrust. And I mean, that's the world we live in. You disclose everything, but our mentors, Peter, would probably never have mentioned it. And
I gotta tell you, Philip, I never tell them. I never tell them if there's a 1 or 2 because it's so benign. There's no point in scaring them.
Yeah,
Especially if I'm
I
not
hear that,
treated.
but it just seems to be the way the world is, and I struggle with this.
Yeah, don't struggle. Don't tell them. There's no point in scaring them.
If it's a survey, I would have to agree with Dr. Pappas on that. Along those lines, if I could, Dr. Malhotra, would you feel comfortable generalizing your conclusions to ultrasound-guided foam sclerotherapy induced thrombus from the heat-induced thrombus literature? Obviously, we see it more below the knee.
What do you think it is? Is there a difference between a foam-induced E-fit
Yes.
or a E-hit or E-get?
yeah.
Yes.
I think it is going to, go ahead.
No, go ahead.
I think that literature is not going to be showing it at this time, but maybe in the future. But it's my feeling that E-hit is pathologically or pathophysiologically different, like Dr. Malhotra nicely showed. But if it may be more close to classic DVT.
That's interesting, Dr. Sufyan, because I found that the foam-induced thrombi resolve a lot quicker. It's very rare that you see them in the femoral vein or the popliteal vein. Most of them tend to be posterior tibial vein because the foam got through a perforator. They tend to be short and focal, and they tend to resolve very, very quickly on their own. Like I put people on a Eliquis for like a week and it's gone, and then I stop it. They tend to be very benign.
It is because of their size and their location. They're very mostly the ones we locate are in the distance.
Very small. I also think that because they end up walking a lot, that calf muscle pump clears it a lot faster. So I think if I saw a 3 or a 4 in the femoral or in the popliteal, I would treat it. But I've never seen a foam clot. And actually, I shouldn't say that. I've had one varithena because I didn't know there was a large Hunterian perforator and it caused the femoral popliteal vein thrombosis. That patient I had to anticoagulate for 3 months before it went away. But it went away completely.
Hey guys, just a comment regarding all the data in here. I can't argue with any of it. All of it is completely true, and it's consistent with my experience as well. The comment about not disclosing E-hit ones and twos, I'm on board with that. There's no issues from my standpoint. The only comment I would make there is, please, if you do that, explain it to your staff. Explain to the staff why you're doing that, because invariably what will happen is I'm going to get a call from somebody that says we're hiding information or complications, and all of that just winds up being a bigger mess. So that goes along with everything that we do. So when you do something, you guys are great physicians, and what happens is every decision making you make is appropriate, but we just have to make sure that our staff understands why we're doing it.
Agreed. All right. Anybody else?
Thank you.
All right, Aditi, good job. It's always a good presentation that generates a lot of discussion. Well done. All right, thank you,
Thank you,
everyone.
Dr.
Have a
Malhotra.
great weekend.
That was great presentation.